Hello, and welcome to our webinar, Introducing the CAT-MH. My name is Ben, and I'm excited to introduce the three expert presenters we have lined up for us today. Starting off is Dr. Robert D. Gibbons, the Bloom-Reese Professor at Biostatistics at the University of Chicago and founder of Adaptive Testing Technologies, the creators of the CAT-MH. He is joined by Hannah Wolchin, a director at Adaptive Testing Technologies. They will be discussing the development of the CAT-MH, the science behind it, and the benefit it brings that can help both the clinicians and the clients that they serve. Lastly, Scott Posson, a senior product manager here at Pearson, will give a demonstration of how the CAT-MH will look on Q Global once it goes live. I will be supporting the Q&A with my colleague, Maggie Morris, and I'll be back at the end to ask any questions that may come in. Please type any questions, concerns, and comments into the Zoom Q&A box at the bottom of your screen. Comments in the chat box will not be addressed. We will answer questions live, time permitting, at the end of the presentation. If we are unable to get to your question live, or if you'd like to speak with a representative, please fill out the follow-up form in the link that will pop up at the end of the presentation. In addition, the slide deck shown will be emailed out to live participants, and a recording of this webinar will be posted on the CAT-MH page on the Pearson Assessment website. That's all I have for now, so I'll hand it off to Dr. Gibbons to get us started. Thank you.
Thank you. If we could advance the slide. So what is the CAT-MH? The CAT-MH is a suite of self-reported computerized adaptive tests for adults based on multidimensional item response theory. That's quite a mouthful. But in the next 15 minutes, I will explain how all of this fits together and why it is a very important paradigm shift in mental health measurement. It was developed over 15 years with continuous funding from the National Institute of Mental Health and other institutes like the National Institute of Aging, who funds much of our current work. It was validated, all of the measures that we're going to be talking about, against structured clinical interviews with using the SCID-5 as an example for DSM-5 diagnoses, and the KCAT, which will be coming soon through Pearson, is for adolescents and adds in ADHD, conduct disorder, oppositional defiant disorder, and has been validated against the KSADS for youth ages 7 through 17. The key feature is that using computerized adaptive testing based on multidimensional item response theory, we can dramatically increase the precision of measurement while completely eliminating clinician burden and minimizing client or patient burden. And I'll explain how that works. Go to the next slide, please. So just to start out, we've developed CATs for many different things. So for adults, the CAT-MH, and what will be available through Pearson is depression, anxiety, suicidality, and suicide risk prediction, mania, hypomania, PTSD, both as a diagnostic screener or computerized adaptive diagnostic screener or CAD, and as a dimensional severity measure. Psychosis, substance use disorder, both in its initial assessment that includes DSM-5-like categorizations of the specific substance use disorders, and then the severity of that underlying substance use disorder that can be used for longitudinal assessments thereafter. Adult ADHD and social determinants of health. Next slide, please. So I'm going to be talking about explaining from a high level what multidimensional IRT-based computer adaptive testing is, how does CAT work, and what do you get out of all of this technology. But initially, let me start by describing the history of these tools. This work has been under development probably as a program of research initially for 20 years. And the reason is this. Computerized adaptive testing based on unidimensional item response theory for educational assessments, things like mathematical ability, verbal ability, have been around for about 30 years. The problem is that for complex traits like depression, where the items, for example, come from domains of mood disorder or cognitive impairment or somatization or suicidality, don't fit unidimensional IRT models. They're much too complicated, and we need multidimensional IRT to be able to evaluate them. The problem is that there never was any form of computerized adaptive testing for multidimensional constructs. During this period of work, we applied to the National Institute of Mental Health to develop such measures and to develop that statistical slash psychometric capability. We were surprised to get a perfect score on the first grant. We developed this technology, and then it led to computerized adaptive tests for depression, anxiety, mania, and hypomania. So it has a long and rich history, both in terms of the underlying statistical theory, as well as the application of that theory to very, very important real-world problems. Next slide, please. So I like sports, and I'm going to use sporting analogies to describe the difference between classical test theory, which is what you're used to, in terms of fixed length traditional mental health assessments, and IRT-based, model-based measurement. So classical measurement theory is a lot like the hurdles. And in the hurdles, the items are the hurdles themselves. And if I were to change the number of hurdles or the distance between them or the height of the hurdles, I can no longer really compare the time it takes to run the race. A similar analogy, and I'll pick on the PHQ-9 because Kurt Kroenke, its developer, is a friend and colleague. Um, Many people use the PHQ-8 because they don't want to ask about suicide, because if you ask about suicide, you have to do something about it. And you really can't compare the scores from the PHQ-8 to the PHQ-9. It's a lot like the hurdles. The same is not true in item response theory. The sporting analogy for item response theory is the high jump, and the items on the high jump are the locations on the bar. Now, this individual is a very good high jumper on the right. He's going to start at about 6.5 feet, move the bar an inch or two in either direction, and we'll know his ability. I am not much of a high jumper. I'm going to start at a foot, build up a little confidence, and by the time I hit 4 feet, I'm going to knock that bar right over. This individual and I have taken no two items in common, yet both of our abilities are measured in exactly the same metric. That is the beauty of item response theory. We don't have to give different people the same items. We don't even have to give the same person the same items over time. But if they have been properly calibrated in advance, we can use those items to do assessments. Go to the next slide, please. So what is one of the things we can do once we've calibrated a large bank of items? Well, we can do computerized adaptive testing, or CAT. So what is CAT? Imagine that you had 1,000-item mathematics test ranging in difficulty from simple arithmetic through advanced calculus. And you had these two examinees, one a lovely fourth grader, and on the right, a poor, oppressed graduate student of mine in the Department of Statistics at the University of Chicago. Now, I could go through the arduous task of giving each of them this 1,000-item test, and if they sat still long enough to take it, then I would have good estimates of their ability. But I'd be giving arithmetic questions to a graduate student at the University of Chicago and calculus and real analysis questions to a fourth grader, which seems like a huge waste of time. Nevertheless, that is exactly what is done with every traditional mental health measurement. Somebody who is severely depressed, we will ask a question, do you feel sad? Because it is one of the questions on a particular test, on most tests. It tells us very little about their severity. Better approach would be, let's start with an algebra item, something in the middle of the distribution, and when the child gets it wrong, move to simpler items like arithmetic items, and when the graduate student gets it right, move to more difficult items like calculus. That is computerized adaptive testing. Now, for mathematical ability, which is inherently unidimensional, it works pretty well. All we have to do is find our way along the real line. We just need to know how far to move. In the measurement of mental health constructs like depression, we have to find our way around a k-dimensional space, which is a much more difficult task. If you could go to the next slide, please. This is how to do it. Don't try this at home. On the right is the book that I wrote with my mentor, my teacher at the University of Chicago. And we finished this book published by Wiley about a month or two before he passed away at age 94. And Darrell Bach coined the term item response theory. So it was fitting that we called the book item response theory. And it describes all of this statistical morass. But the most important thing is probably the bottom equation. In item response theory, not only do we get a point estimate for the severity of the underlying disorder, we also get the uncertainty in that estimate. And that's really important because it allows us to say, if I'm a clinician and somebody is measured on a 100-point scale, and they started out at 70 and I moved them to a 68, but the precision of measurement is 5 points. I didn't do such a good job because I'm still within the uncertainty. But if I move them from a 70 to a 60, that's 2 sigma. And that's both statistically and clinically significant. Next slide, please. So how do adaptive tests work? Well, we start by administering a question with medium severity. Maybe it's that, do you feel sad or something a little further, a little more severe. On the basis of the response to that first question, we estimate the severity and the uncertainty in that. And it's terrible. The uncertainty is very large and our estimate of severity is very poor. But on the basis of that poor estimate, we go to what is a very large item bank. In our case for depression, it has 400 items in it. And we inspect the remaining 399 items and select the most maximally informative item conditional on that poor estimate of severity. We administer it, recompute the severity, recompute the uncertainty, and then on the basis of those, we see that the uncertainty just decreased a little bit. And we iteratively go down the list of selecting the next most informative item and then the next most informative item. And we end the assessment once we've reached our targeted level of precision, which is 5 points on a 100-point scale. Typically, we achieve that in about 8 to 10 items out of a bank of 400 or more items. And the beauty of this is that we can reproduce that 400 item score with almost perfect accuracy using an average of 8 or 10 items. What we have done is produced, as an example, the PHQ 400 that has 40 times the precision of the PHQ 9, yet requires no additional effort or patient burden than a 9-item PHQ. Next slide, please. So from an accuracy and precision perspective, the CADMH and the KCAT are very different than traditional fixed length assessments. There are 3 scenarios that characterize traditional assessments. They can have low accuracy and low precision. On the left-hand side, they're biased. They're not accurately tapping the underlying latent variable, often because they're not very long, and the items are not necessarily all of uniform ability to discriminate high and low levels of psychopathology. They can have low accuracy, but high precision. So they keep telling you the same answer, but it's always the wrong answer. They can have, on average, good accuracy. They surround the target in a uniform way, but they have low precision in that they never really hit the target. Or the CADMH or KCAT have high accuracy because they're based on extremely large item banks, 200, 300, 400 items in the bank, and they have high precision because we continue to administer items until we achieve 5 points on a 100-point scale. Next slide, please. So, what do you get for all of this mathematical wizardry? Well, the first thing you get is a constant precision of measurement. So, traditional measures fix the questions and allow the precision of measurement to vary. Multidimensional IRT-based CAT fixes the precision and allows the items to vary both in number and in content. And it also allows us to measure with very high precision people who might have subclinical psychopathology or moderate suicide risk, whereas traditional measures usually have much higher uncertainty in people with lower levels of psychopathology or suicide risk. Because we're not asking the same questions to different people or the same questions repeatedly over time to the same people, we eliminate response bias that occurs for traditional measures when we ask the same questions over and over and people just remember how they responded before. People actually like taking computerized adaptive tests because they're wondering what is the next question to be asked. Remarkably, in our review of the literature, very few traditional measurements have been rigorously validated against structured clinical interviews for the underlying diagnoses, like major depressive disorder, generalized anxiety disorder, PTSD. We have, because of a rich funding source in terms of NIH continuous funding of this work, been able to validate all of these measures against structured clinical interviews, like the SCID for DSM-5. And in addition, we have, as I mentioned before, a severity estimate in addition to precision or the uncertainty in measurement. Traditional measures do not measure precision. We have no idea if that magical cut point of 10 on the PHQ-9 for real depression versus not has an uncertainty of 1 point, 2 points, or 3 points. Here we know exactly what the uncertainty is, and it allows us to do measurement-based care and be able to assess change. Next slide, please. And I think that's the end of my portion. Now I'd like to pass this over to Hannah Wilkschen.
Hi, everybody. Great to be here. Thanks so much, Robert, for sharing a little bit about the history and development of the CADMH. But now we wanted to sort of shift things and talk a little bit more about and provide some additional information about what this looks like in practice. So what using the CADMH will give you. So next slide. So here you'll see the three core metrics that are provided. Robert has mentioned several of these as he's discussed how these were developed, but we wanted to briefly touch on what those look like. So for all of the, or for most of the measures that you'll find in Q Global, you'll find a severity score as part of the output. Severity is measured on a 100-point scale, with 0 being the least severe and 100 being the most severe. So higher scores reflect greater severity of symptoms. You'll also find a category. This is a clinical classification, and that typically is normal, mild, moderate, or severe. For some of the modules, you'll also find a low, medium, or high risk as part of the output. And finally, as Robert mentioned, the precision, which is what makes the CAT so unique. The precision tells us the uncertainty around the score. Lower precision numbers mean we're more certain about where someone truly falls. And so we've fixed that precision to roughly 5 points. Precision is also measured on a 100-point scale, with 0 being absolute certainty and 100 being absolute uncertainty. Next slide. As we talked about briefly, we have the different modules listed here that you can see available for administration. So depression, anxiety, suicide, mania, hypomania, PTSD, substance use disorder, psychosis, ADHD, and social determinants of health. This is a high-level overview of each of the different modules. So here you'll find the number of questions in the item bank, and then what the outputs are for each of those. You'll notice for things like PTSD, which is a CAD, you will get a diagnostic output. So that will give you a positive or a negative result. You'll also find the reproducibility column, and that represents the degree to which the results are reproducible to the entire item bank. So in other words, how closely the score would be, how closely the scores would compare if someone were to take all 389 items, for example, in the depression module, compared to the results that you would get from taking the CADMH. Finally, on the right-hand side, you have the administration column, and that gives you a little bit more information about either average completion time or the number of items that are typically administered in one of these assessments. These are able to be put together to create, sort of a profile of individuals, and Scott will share more what that looks like in the Q Global platform here shortly. Next slide. So problem solving, we want to talk a little bit about what the why is and what some of the problems that the CADMH is solving. So as you can see here, eliminating the clinician burden. So you're not scoring paper screeners or administering long clinical interviews. This is all done through the Q Global platform. And there's a lot of different benefits that we'll get into on a use case specific basis here shortly. These are targeted, personalized assessments based on the needs of the client. So it reduces the client burden in the sense that people are answering the most informative questions for them, for their specific level of severity at that point in time. It also allows for repeated measurement without duplicating items. It's fast yet validated. So oftentimes 1 to 3 minutes per module, which you saw in the previous slide. It also adapts to each person. And so from one person to the next, or from one administration to the next, we're able to look at the differences. The CADMH meets clinical, operational, and patient experience needs all in one package. Next slide. So some other benefits, this slide expands on the broader applications. So the streamlined assessment. So instead of doing each of the different domains that we measure in an individual assessment, you have this streamlined way of measuring a wide variety of mental and behavioral health domains within a single assessment. So moving from one domain to the next in a continuous stream of questions. There's a wide variety of applications, which we'll go into in detail in just a few minutes. And the highly validated nature means that the results are telling you what you'd find with that full structured clinical diagnostic interview. Next slide. So we are now going to shift sort of to those use cases, and Scott is going to talk about what this looks like in the Pearson universe. Scott?
Hey, Hannah, I think actually you have a couple more slides. So,
Yes, yes.
oh, do you want me to cover this one?
Yes, I think you're better suited to cover this one.
Can certainly do that. Thanks, Hannah. And good morning, good afternoon, everybody. So the nice thing about CAT-MH is that it's been slotted in as a level B assessment and those of you who are Pearson customers are very aware of that. So similar to some of our other survey assessments in this space. Who can use it? It's available really to all allied health professionals and mental health professionals. So it might be any in the general mental health space, psychologists, counselors of all types, social workers, psychiatrists, MDs, and nurses. I'm not sure how many of these various types are represented by our attendee list today, but I'm sure there's a variety of them across that. And where would you find these folks working? Well, obviously you work everywhere. So this will be very, very appropriate for use in private and group practice. You might want to use the CAT-MH to do an initial assessment prior to ever meeting a client, so that you have the results of their test when they come into your office. Hospitals and clinics have been using the CAT-MH for a variety of reasons. You can look at emergency room or emergency department triage, or certainly clinical triage in any type of setting, government agencies, Veterans Affairs. So pretty much everywhere where you're working, this would be an appropriate tool. And hopefully Hannah will be able to tell you a little bit more about that in the next slide. Thanks,
Absolutely.
Hannah.
Thanks, Scott. Next slide. So the next slide represents sort of the breadth of the CADMH's user base. So these logos all represent universities, government organizations, and many other types of organizations that have partnered with adaptive testing technologies to use these tools and to develop some of the um, modules that have come out of the development of the CADMH. So as Professor Gibbons mentioned, we started with the CAT DI, so the depression inventory, and that was the first CAT based on multidimensional item response theory. And from there, we've grown the offerings to what you see here. So all of these are very good partners of ours, and we are lucky to have been able to work with a lot of these organizations. Next slide. These are some current uses. It's an introduction of the different settings where the CADMH has been used. It shows how flexible it is across environments. Scott just mentioned that many of these are use cases for Pearson users as well. The system is very adaptable and the applications vary. So intake, ongoing monitoring, triage, remote administration, all using the same tool. Each sector uses the CADMH for slightly different reasons, and we'll talk about some specific use cases in just a few moments. But I'd encourage everyone to think about the different use cases in your work, and feel free to chime in during the Q&A sessions if you have specific questions about how this tool could be applicable within the population that you work with. Next slide. So I wanted to highlight a couple of different use cases and just talk a little bit about how each one of these works. So here we have an example of how the tools are being used in a primary care setting. So this looks at the workflow where assessments are sent ahead of an appointment. So they're completed remotely, and then the provider is able to review the results ahead of time, informing the appointment that they have with this person before they've even walked through the door. So even if it's not completed, there's an opportunity for it to be done at the appointment, at the start of the appointment, since the time required to complete it is quite short. Using this type of workflow allows for faster appointments, better and more informed decision making, and implementing measurement-based care within an organization. Next slide. So here we have some examples and some discussion about using this in private practice, which we've done many times. This illustrates the support of remote monitoring. So it reduces in-session assessment time. You're able to get to treatment faster. It does things like helping to track medication effectiveness and titration, supporting clinical decision documentation. So for example, justifying a discharge or identifying early symptom increases before the client reports or even before their next appointment. So you're able to get ahead of things and approach treatment in a more proactive way as opposed to being reactive. It's a powerful tool for solo and small group clinical practices trying to manage caseloads efficiently, triage, understand who needs the next appointment, and things like that. Next slide. And finally, the last example is the university mental health. So student wellness centers and sort of how they've utilized these tools. So in a sense, the goal here is to help identify at-risk students sooner. So understand who needs help now, and doing that in a way that is simple and scalable. So student mental health centers are able to view the results of the CADMH and flag those who may need help. It digitizes the initial screening process, which reduces intake bottlenecks, allowing organizations and universities to allocate resources more effectively, and ensuring students get support before they reach a crisis point. So as you can see here on this slide, there's a example of sort of a stepped care approach where the assessment is completed, and based on whether there is an evidence of, in this case, depression or not, there are different levels of of care that each individual is triaged to. So hopefully that gets you thinking about some of the different ways that you could use the CADMH in your work. And I'm going to pass it over to Scott now to show us how it actually works in the Q Global system.
Thanks very much, Hannah. And so I'm going to switch over to Q Global here, and you'll notice that while we were waiting, my system has timed out, so we're going to have to sign back in again. But you folks are going to know all of this if you're Q Global users. I'm going to be looking at this within our staging environment, which is just the last step before we finally release, and we'll be releasing here in about 3 weeks' time, and you'll be able to use CADMH. So. For those who know Q Global really well, this is a list of clients or examinees. So we're going to select an examinee as the very first step, and then we can assign a new assessment to that examinee. I've got CADMH set up here in my favorites, of course, but you could search it through the All Assessments tab as well. We're going to assign that. And when we do that, we come to the Create Administration screen. So there are two different ways you'll be able to administer CADMH. You can do it in person in the office on screen, or you can, as we've talked about, send a link via email out ahead of time for a remote on-screen administration. So both options are available. I'm going to click on in person online, of course, and then you'll bring up the assessment options and settings screen. And you can see here the things we need to configure ahead of time before we administer the assessment. So we can administer the test in either English or Spanish. This is something the examiner must know ahead of time. It's not configurable or changeable in the actual test administration itself. So we'll go with English. Time frame is selectable. The standard time frame is past 2 weeks, and that's the default. But as you can see, there's a lot of configurability in here. Hannah mentioned medicine titration, so you could actually do this in the past hour if you wished, or past 12 months, or what have you. I'll point out here that whenever there's a coach mark, you can hover over that, and it'll tell you a little bit more about the options that present themselves here. Population, there are 3 different populations that you can choose from. The general is the default, but there are configurations for criminal justice and perinatal populations. These are not different normative groups, and as you know, the CADMH is not a normative assessment. But what this does is it deselects some of the items from the item pool that would be confounding for that particular population, whether it be criminal justice or perinatal. And the easiest way of thinking about that is if you think about a perinatal population and you're assessing depression, you don't want to ask that new mom if she's tired all the time, because we know she's tired all the time. So that's not a particularly interesting item for us. So that's the options that are presenting there. And then you can come down, and here are the 9 different domains that you can select from. They're all available in the same assessment. There are 11 different modules across the 9 domains. So if I want to select them all, let's say this is an initial assessment, all I do is I just click through all of these and add them. And that would administer in a continuous stream all of the items in the item bank relative to each of those domains. I'm not going to do that because that'll take us a little bit too much time for today. I did want to point out one other thing. If I'm in the substance use disorder area, I can only administer one or the other of those substance use assessments that Robert spoke of. The initial assessment would be the one I might probably do first, and the same thing happens with PTSD, either diagnosis or expanded. The expanded issues for outcome monitoring more typically. I am going to, for today, just use depression, anxiety, and suicide. And so we're going to launch this assessment right now, and you'll see how easy this is to do. You're familiar with this screen. This just locks people out of the browser. And we're now going to the administration platform for the CADMH. You'll see this initial screen tells us there are no right or wrong answers. I can disable or enable the audio button up here on the top left-hand corner, and I can just begin the questions.
Answer the following questions based on how you felt over the past 2 weeks unless otherwise specified.
So that you can see in bold here the past 2 weeks, and the voice told us it was the past 2 weeks. That would obviously change if we configured to a different time frame. We hit next.
I felt depressed.
So I felt depressed most of the time. I'm going to turn the audio off for you folks so we're not having that. And I'm going to go through this reasonably quickly, but hopefully you'll be able to keep up as I go through the process of going through for the next and most informative item for this particular pretend client. How much of the time was I depressed? I felt gloomy. How much did that interfere with what I was doing? I felt bad, very sad. How enjoyable have things been, or not enjoyable in this case? How much were you distressed by feeling everything was an effort? How withdrawn have you been? Have you been feeling sluggish? Fatigue interfere? It scared me. Now, if you're paying attention, we've just moved into anxiety. Of course, the patient doesn't know that, or the examinee doesn't know that. But we're just responding to each of these questions as they come along. Am I distressed by trying to avoid things? Have I felt afraid? Bothered by not being able to take things in when speaking to people? I felt hopeless, been downhearted and blue. Now we're into the suicide modules. You can tell how often I feel that others would be better off if I was dead. I felt like a failure. And I've been distressed by feeling hopeless, troubled or bothered. Have I been discouraged? Have I felt inferior to others? And I am finished. So that if I'm the examinee, I'll just say, okay, I'm done. I click that back off. And for those of you who know Q Global very well, I need to sign back into Q Global so I can see the results of this assessment. I pick the client again, open up that client, and then I can generate the report. You see it's sitting here ready for reporting. I generate that report. I use a usage. Important to point out here, if I do 1, 3, 5, or 9, it's still a usage, but you can maximize your value by doing as many of the assessments as are relevant for that particular client. One thing I wanted to point out here, in the report options, you can include or exclude the examinee name or the item responses. Very important, we think, to include the item responses because the items are always going to be different. So you want to know what that particular client has responded to. And then we create the report. Now, because we're in a test environment, this might take a little bit longer than it normally would. But if I refresh this data here in about 10 or 15 seconds, I'll be able to download the report. So here we are. So it's downloading, and this is the report. So you'll see this is the report for this particular administration. So we might as well go through it really quickly. You'll see the cover page. There is a static interpretation page, which is nice to have on there each time, reminding you what the scores are. And a note that says, if the suicide module was administered, please carefully review the risk category and the responses. The other thing to note is when suicide is administered, it wouldn't necessarily be the first of the modules administered, but it will always be the first result that comes up. If you've administered 3 or more of the modules, you'll get a score results summary table. So you can see here we have an intermediate risk for suicide, severe depression, and severe anxiety. Each of the modules will then print out. As I mentioned, suicide will be first, and you'll see the time frame, the category, severity, and precision. So very high precision, right around that 5 that Robert was talking about, and the severity is quite high, 68.5. And there you can see each of the items that were administered to the client in the suicide battery. Wanted to point out this one little thing here. It says, have you felt that life wasn't worth living? And if you remember, that was actually one of the first items that I responded to, and it was during the depression test. But because it was asked in depression, it's pulled over by the system and used in the suicide module. And that's why the duration, the time it took, was is left blank because it didn't take any time in the suicide administration. And so you get here the item, the response, the duration, the severity of each at that level for each of the items, the category, and then the precision. And as you'll see here, as Robert and Hannah both mentioned, the precision decreases over time or with each item until we get to the level of precision we're hoping for or wanting. Same thing with depression. You'll see the same severity precision categories. You'll see a probability of major depressive disorder, very, very high in this instance, and then a percentile of those in the sample who had a diagnosis of major depressive disorder. What is the percentile equivalent? It's 85.6. And for those systems that are using PHQ-9, if it's helpful, we've given you the equivalent of that, the PHQ-9 score equivalent to this CAT-MH administration for depression. We don't recommend interpreting that because the PHQ-9 was not given as part of this assessment. Then you have anxiety, and then you are finished. So that is an example of the score report. I'm wanting to look here to see if I have a longer one. I do not. So I am going to say thank you very much. Hopefully you found that interesting and get a good sense of what the system looks like on Q Global. My last slide. You can learn more about the CAT-MH on our product support page or our pearsonassessments.com/CAT-MH page. You'll see the interpretation guide or the interpretive guide there available for download. It'll also be available free of charge on Q Global in the resource library. You are able to order CAT-MH now. It's going to be available for use. It's scheduled on our next Q Global update, which is December the 6th. And look for more in-depth training options coming early in 2026. Watch your email and sign up on our website. So with that, I'll turn it back to Ben. And Ben, do we have any questions that may have come in?
Hello, we do. Thank you. We got quite a few coming in, so I will try to get through as many of these as we can. Let me just slide this on over here. All right, so this first one, back on the slide where Hannah was showing some of the modules in the chart, someone had noticed that the item bank count and reliability was missing for suicide, and we're just kind of curious if that is shown somewhere or if there was a reason that it wasn't presented at this time.
Robert, would you like to, do you have that figure off the top of your head? We can go find it, but I think it's just missing in
I think it's just missing
the chart.
for all of the cats that we've ever developed. The correlation between the adaptive test and the full item bank administration is in excess of 0.9, and typically more about 0.95. So they're very, very good at reproducing the full item bank. And a lot of that's due to the way that we tune the cat. We look at 1,000 different possible combinations of cat tuning parameters, and we select the one that maximizes that correlation while at that same time is minimizing the burden of measurement. So we pick a series of 3 tuning parameters that allow us to have correlation with the total item bank score, typically on the order of 0.94, 0.95, 0.96, and limit the number of items that are administered to an average of about 10.
Appreciate it. We have a couple around sort of a manner of presentation or response style questions, and they were curious if conceptually could a manner of presentation type module be developed where it could be validated against other response type scales that may be found in some other assessments?
The beauty of CAT based on multidimensional item response theory is that there is no construct that's too theoretically complex to be able to not be amenable to creating a CAT for this technology. Our current work now is on not asking questions but using tasks in cognitive assessment. with the idea of being able to reproduce a day-long assessment by a trained neuropsychologist in about 10 minutes using adaptively administered tasks. So a wide variety of cats are available for lots of different applications. You'll see here that we have a cat for social determinants of health, which is quite different than psychopathological constructs, yet very, very important in terms of making treatment decisions and judging suicide risk and a variety of other factors.
Appreciate it. Thank you. We have several coming in around malingering or over-reporting, under-reporting, validity scales, and things like that. Basically, what are your recommendations for anyone who might be concerned about malingering or over-reporting, or are there any ways that the cat can be used to sort of detect that?
Right, it's a really important question. So we do a lot of work in the Cook County Jail with our Sheriff Tom Dart. We've assessed thousands and thousands of people who are incarcerated and have been developing models based on the score vector across depression, anxiety, mania, hypomania, suicidality that can be used to determine whether or not a person is going to have increased or decreased risk of reincarceration. So treatment programs within the jail can actually change levels of depression or suicide risk, and they in turn have big effects on distal outcomes like reincarceration. But of course, malingering is a very important concept. At the most basic level, we record in milliseconds the amount of time that it takes to administer these tests, and we have performed millions of these tests. So we've been able to deconstruct the distribution into malingering component in terms of the time it takes to answer on average across the questions. It's about 2.5 seconds. If you're answering less than 2.5 seconds, you're being somewhat disingenuous. But we're also trying to go beyond that. We're also trying to use machine learning models to identify patterns of responses that are characteristic of malingering. And that's an ongoing area of research and hopefully soon to be incorporated in practice. But important area, really important question.
Appreciate this. This one might be a little bit more for Scott. People were looking for some sample report PDFs of the CAT-MH. Do we know about a time we might have those posted on the site?
I think you'll start to see those later this week, folks. Because we're still in this pre-release stage. We're still working on some of the reports and making sure that they're pretty and look nice. But we'll get those up. They'll be on the resources tab on the CAT-MH program page soon. So yes, there will be sample reports. I think it will provide a variety of them, some fairly straightforward, and of course one that has all of the modules in it. So you can take a look at the various scores and how those different modules report out. So that's a great
Appreciate
question.
that.
Thanks.
This next person had concern about measures being sent to a client that prevents clinicians from making behavioral observations during the tests or having the clients from asking questions if they have any. So this test is not only being able to send out, but you can do it live in person. Is that correct? As long as there is a computer available?
Absolutely, yes. Mhm.
Hannah, do you want to take that or do you want me to?
You can go ahead and I'll fill in any blanks.
Sure, it's a great question, and both can be used, of course. Many clinicians actually use the administration of the CAT-MH as a part of the the clinical session, and they discuss the responses to the questions and give the opportunity for asking questions. In general, we don't find, even in early adolescence, the need for counseling people about how to respond to these questions. They've been assessed in ways that make them very easy to administer and to understand. And of course, you can use a mixture. It's always good to be able to initially screen people. And then if you want to, if something doesn't make sense, you can re-administer the tests at any interval in time. to look at, test retest reliability, or if there was issues in terms of the remote testing session. So you don't have to do it, but it's extremely useful to have that information even before you sit down and meet the individual.
Appreciate it. Thank you. I know you had discussed this one a little bit further, but reiteration is good. So they were kind of curious about how the questions do they change based on previous responses?
Absolutely. The algorithm is completely dynamic and adaptive. And so, um, based on your response to any question, we are recomputing your severity level and on the uncertainty in that severity level for that particular domain, and then going out to the bank of remaining questions and selecting the next maximally informative question conditional on that current estimate of severity. So depending if you start to answer in a very severe way, you're going to get more severe questions because it's going to change our estimate of your underlying severity. So we target the items that you receive to your severity level, which of course we don't know, but we learn through the adaptive administration of the test.
Appreciate it. Thank you. Um, so this person says they frequently evaluate college-age adults for ADHD and other learning difficulties. They said since some people attest to symptoms, excuse me, consistent with ADHD, but there may be other causes, they were curious about the CAT MH's ability to differentiate diagnoses, whether it's ADHD in addition to anxiety or versus anxiety or, other learning disability diagnoses, stress and things like that.
It's a great question, and the issue of comorbidities in mental health diagnosis is a very complex one. Because the CADMH, as we saw in Scott's demonstration, he looked at, I think it was depression, anxiety, and suicidality all simultaneously as a continuous string of items, as opposed to, maybe administering the PHQ-9 and then the GAD-7 and then the Columbia scale or something like that, or the ASQ. You really don't know which you're being assessed for, and we'll be able to look at the probability of the underlying diagnoses accordingly. All of these have been validated against those diagnoses. So we know that if ADHD is in the severe category, that the likelihood that you are suffering from a clinical diagnosis of ADHD is extremely high, but it doesn't rule out that you might also be suffering from some form of generalized anxiety disorder. We're able to, because we have, we validated all of these against the case ads, we have, been able to identify ADHD in or with or without a comorbidity. But the point that I was trying to make and that I forgot is that how do you know that in an autistic population, a measure of ADHD or any of the other psychopathology measures are valid? The experience of autism may impact our ability to measure other forms of psychopathology. And so we have studied the KCAT in an autistic population and identified those items that are biased in that population so that we can come up with refined measures of psychopathology in the presence of autism. So it speaks to this idea of comorbid disorders and my ability to and my failure to sort of find my way through that question is an example of why I need to use the CAT cog to evaluate my cognitive impairment.
Appreciate this. I'll give you a short break and give this one over to Scott. Will this be available on Q Interactive at all?
That's not planned. As our folks who know Q Interactive and Q Global, Q Global is the system that we use for administering our fixed choice types of assessments, of which the CAT-MH is one. Q Interactive is more broadly used for our interactive assessments like the Wechsler scales. Now, having said that, I'd never say never. We don't know what will happen down the road, but there are no current plans to put CAT-MH on QI.
Appreciate it. Do we know about an average reading comprehension level needed for this assessment?
I believe for the CAT-MH, we designed the questions and then evaluated them for a fourth grade reading level. And one of the reasons that we put in the audio is to deal with issues related to literacy. So with the switch of a button, as Scott illustrated, you're able to either have audio reading the questions or not.
Appreciate that. Are there any studies, peer-reviewed articles, journals, or things like that that someone may be able to look up and find to get more research on this outside of this presentation?
There's over 60 peer-reviewed articles on the CAT-MH and the KCAT. So we have published exhaustively over the years and continue to do so today as new applications become become available or new measures become validated. And a listing and availability of most of those publications are available on the Adaptive Testing Technologies website.
And just Ben, I'll mention to folks on that same www.pearsonassessments.com CADMH page, you will find a citation list and a reference list for which is current up until last month. So we're good there. So you can always take a look at that if you need some bedtime reading.
Appreciate that. I've read a few myself and looking forward to catching up on all of them. How does this differ from the patient reported outcomes measurement information system, if anyone here is familiar with that?
Yeah, it's a good question. So PROMIS looks at a wide variety of areas outside of psychopathology, and they've developed many good instruments. Uh, that's not necessarily true for mental health instruments. Their depression and anxiety item banks are, I believe, 26 and 28 items individually. So, we have 389 and I think about 437 items in those two banks. It's very hard to, and they have both fixed length versions, and I believe they have computerized adaptive tests. Their computerized adaptive tests borrow from educational measurement and are based on unidimensional item response theory, which underestimates the complexity of the underlying latent variables of depression and anxiety. What happens when you do that is you underestimate the precision or you overestimate the precision of measurement. The standard error, the uncertainty is too low. And that leads to premature termination of the CAT. So you don't have the level of precision and the information content that you would with the CAT-MH. Finally, if you only have 26 depression items, your CAT is basically carving out a fixed length measure out of those 26 items that the items that have the strongest discrimination will always be administered, and basically you just have another PHQ-9.
Appreciate that. I know we're getting really close, so I just want to remind everyone there will be a form that pops up. You can submit any feedback or questions, and we will certainly follow up as best we can afterwards. Just one more. Sorry. So someone had mentioned you had mentioned that we have response time and we collect that information. Can you give any guidance or interpretation you might for a response time that may be, longer than 5 seconds or even further than that, that may be sort of standing out compared to other responses?
I think the most important anomalies in terms of response times are those that are too slow. I mean, too quick. So people are just kind of banging through this and really not paying attention to the questions. And you can see that in terms of the uniformity of category choices and the speed at which they respond. So if they're responding in 2 seconds per item, you know they're being disingenuous. There are many reasons why people might, take a longer time on a particular item. A mother may be, having to attend to a child and takes a break, for a minute or two. It's not that it took her a minute or two to answer the question. It just something else was going on. So longer response times are not necessarily indicative of problem areas. Although I've talked to many clinicians who use the length of the response time to start thinking about targeting to particular symptomatology and saying, oh, that's kind of interesting. What's going on there? And as we move forward and the integration of large language models into the CAT-MH for the purpose of interpretability, the timing as well as the responses to the individual items, as well as the scores and precisions, will factor importantly in that future work.
Excellent. Thank you. Well, we are at time for now, and I'm respectful of everyone's time. So I think we are going to end it. Like I mentioned, we can always follow up after. Is there any last things anybody wants to say before we head on out of here?
We
If
appreciate this large attendance. Thank you, Scott, and I hope this has been interesting to people. This has been a passion of mine. Measurement is terribly important. It's very statistical, and mental health, substance use disorders, and suicide risks are so fundamentally important to our society. We have to do such a good job in terms of measurement, and hopefully these tools will help us to achieve those goals.
All right. Thank you very much.
Wonderful. And thanks everybody for joining us. Thank you, Robert and Hannah, for participating as well. And have a great day, everyone.
Thanks, everybody.
Thank you.